Lena came to the University of Michigan, I guess, in 2005. I came after her as one of her recruits, so I was not there for the beginning of this entire process. I think the charge today was for Lena to talk about how she worked to transform or change a process at Michigan where the ICU was an open surgical ICU to one where there was a more closed model, intensivist-driven, and also with a patient and family-centered care focus. And you're going to have to help me out here, guys. I know that it's possible that Susan and Kathy Kapersky and Michelle Reed and Rebecca are here, and they were here. A lot of these guys were here for this actual process and can answer questions that I can't. All right, so Lena wanted to be grateful to the SCCM Project Dispatch as a new effort to improve quality, effectiveness, and accessibility and cost-effectiveness of healthcare by looking to develop resources for critical care clinicians focused on patient-centered research and patient-centered care. It's made possible through AHRQ, and Bruce Kleinpel and Tim Buckman are the co-chairs for the organization. Now, this is a slide, I think, from 2005. This is about the 2005 SCCM logo. At that time, that was, and it still is, the slogan was the right care for the right patient right now. And in 2005, that's a commitment Lena tried to make to deliver the right care at exactly the right moment in time to try to optimize patient outcomes. So her goals when she came on, and this is the busy kind of slide. When you're starting a project, I think that this previous speaker alluded to how wonderful it looks on paper, how you're going to make it happen, to have the intensivist-led multidisciplinary critical care team, started in 2005, try to focus on evidence-based critical care, try to focus on the patient outcomes, standardize the protocols and policies from what was very much an, Michigan is full of a lot of very strong surgical personalities, and there was a lot of idiosyncratic practice that was not necessarily based on anything more than preference. You try to implement preventive strategies and try to show some cost reduction when possible. So in 2005, they began a journey to establish an ideal patient and family-centered care experience and put together a multidisciplinary team. And I have to say that, in truth, having come from outside and looking inside, it is true. There is definitely a multidisciplinary functional team at Michigan that involves the physicians, very strong nursing, pastoral care, social work, dietaries coming, pharmacy. We had a great critical care pharmacist, and they really do focus on bringing the patients' families in. I came from an institution, and maybe it's just because I'm older, I was the eye roller, right? I was one not making eye contact and doing the lateral violence, and not necessarily establishing an environment that fostered the concept of being responsive to the needs and choices of patients and families. If you had asked me about family presence in CPR situations, I probably would not be, repeatable in this forum, right? I'm a trauma person, just like Tim Buckman. So 20-bed unit, caring for a wide variety of critically ill patients, and we had some vascular originally, that moved to the cardiovascular unit. We did specialty and transplant surgery, and I don't know, I came from Philadelphia, we had high acuity patients. Maybe they were split up among all those competing hospitals, but they all seemed to land from the rest of the state of Michigan. The acuity is very high. I have to say these guys do a really great job for some very sick patients. We were a regional ARDS referral site, and I didn't do ECMO in Philadelphia. I got to give 3 talks on it at this meeting this week. We are a regional center. It's a proud history developed by Bob Bartlett, who was the ICU director, the first ICU director at Michigan. So ICU patients, we know that they can't communicate their wishes, so that we must focus on the families and the patient advocates to try to maintain the focus in the right place and to try to collaborate and share information. So using evidence-based guidelines from this society, from AACN, and from the Institute of Family-Centered Care, our goal was to adopt a concept that the presence of and the care of the patient and family was a critical aspect in optimizing patient outcomes in the SICU. I'm not sure I can show you the kind of causal data that I might want to be able to show you, but I can show you parallel data, and definitely at least there's an association. So, and these efforts were recognized. I'm proud to say they're recognized by this organization in 2011 and 2012 with the Patient Family-Centered Care Award. So I think my job, my task today is to try to share some of what is done by the group that Lena leads and that I have the privilege of working with, and to see if that can open up some dialogue. So the things that we would consider to be, or Lena drew out to be the tenets here, were to talk about the SICU as a patient family care centered care unit, to specifically talk about that issue of what do we do with the patient and family participation in rounds. Talked about debrief meetings and panels to involve the recovered patient to bring the patient who's been through a critical illness, whose life has been saved, who's back to regular life, to have them come back and bring that recovery back to the ICU as an inspiration and as a way to remember what it is to recenter us about what we're really doing. I'm also going to show you a bunch of slides, not just about the diary project, but also about keepsakes and mementos, and then some more active things as well, blogs and therapies that we share with the patients and families. And I think the resources that are put into this are pretty amazing and are one of the marks of excellence for the institution. Okay, the first one is the Patient Family-Centered Care, and this is where the kudos goes out. There's a team. This is Mary G. down at the bottom here. Where's the little cursor? And she had recorded a bunch of audio for some of these pictures, and I'm sorry it didn't come through consistently. But she and a pretty large and committed team from the nurses. There's 90-plus nurses in the surgical ICU. This list here just represents some of the people who are participating in patient and family care, and I have to say this is the leadership up here. So Marianne Bettis, if I tried to keep a family out of a room because I might want to do a procedure, I thought it might not, I just wanted to have control of an area, she would not let me do that, and I would have to back down. Sharon Dickinson, if any of you know her, totally, I think she's a great clinical nurse specialist. She really pushes and advocates for the families. All these people on this side as well. I think, I knew I was coming to a union state, but I didn't really know that it was going to be quite like this. There are a lot of people involved in making the unit run, and I know at your place, too, there are more people than you realize. So we have trainees. We've got 6 critical care surgery fellows, depending on the year, 6 anesthesia fellows now, 4 pediatric critical care fellows. We're bringing on an ER fellow. So all these people are circling through, and I absolutely recognize what you guys were talking about, that we have this multiple different cycles, all in different, to a different tune. The fellows are changing on Wednesday, but wait, they have to have a day off, so there'll be an extra night shift for one of them, and then the attendings, we'll switch on Monday, and then the residents, anesthesia will switch on Tuesday, and surgery will switch on Thursday. And, it's just suddenly this idea of having continuity means that nobody knows what's going on. So all these people, and then they have nursing. You have, we're talking about physician assistants and advanced practice nurses as well, bringing more people in to try to make sure that we can keep the focus where it's supposed to be, not on us and how we're dealing with handoff and are we saying the right things, but really on getting the patient taken care of and trying to address their needs. All right, so a formal committee was formed. They began setting forth guidelines surrounding open communication and family participation, and this extended not just, I should say that the open communication also extends to things like if the patient's in isolation, and now you guys, I want you to take this back to Sharon that I said this, that the patient is in isolation and I forget to Purell my hands or maybe put that plastic gown on, anybody in the unit is empowered to say, excuse me, you're supposed to wear that, and I have to say yes. And I do. I mean, it's absolutely, we work together to try to make the outcomes better. We work together for the family participation. To move towards that experience, they looked at the current state of the unit and then said, well, what can we do? Now, this is a slogan that I'm not sure I understand completely, but it's the guiding principle that the committee came up with, which is nothing's about me and nothing without me. So the patient and family care centered program it will act as a forum, and the committee can act as a place where family concerns can be defended and focused on. So inclusion in rounds, this twice daily rounding thing, we'll be rounding endlessly. However, in the beginning, they actually had a sign and this really old easel, right? No visiting physician rounds in progress. I've never had that. We didn't have in Philadelphia. But now, I can tell you this is Mr. C, this is Mary, and this is John, this is our previous fellow Constance and Michelle. This is the cow, the computer on wheels that we're all stuck to now, right? I'm sorry, these things are not quite the aspect ratio is not quite right. But when we're rounding, it is not unusual to have a family member come out. And, I think that this isn't a posed photo, and I think the patient's family members actually in the circle, as well as the nurses, as well as the fellow. This is where the sound was. This is a patient who was chronically critically ill. He had PCP infection, ARDS. His family was there every day. There were issues about his HIV status, which nobody knew, his family members, who his loved ones were, and he was in the ICU for months. And that family just came, they talked to Mary, they expressed what it meant to them to be on rounds, to be included. They were asked if they felt like they had input into his care, and this is his father here, and he said yes, they felt like they participated and understood, and it helped address the family's inherent, basically, fear their son was going to die in a way that they didn't really want to happen from a disease they didn't want him to have. And that being able to participate on rounds, they were a great family. They asked questions. They didn't try to control. They did some of the internet stuff, but not too much. And then they came back actually last month, just before Christmas, and they bought dinner and cookies and presents for the nurses. And they contributed as well. They contributed to one of the patient initiatives that I'm going to show later. So the other thing, this one, I always thought that there was a sacred time, where you could sort of just get back and there's no one else there, and you as your team, the nurses and fellows and residents, could talk without the patients, but that does not exist at Michigan. There's no formal visiting hours, and they are allowed to come. Family can come in, except for the post-op, the PACU. They're not, for some reason, that the anesthesiology people do not necessarily apply this in the post-anesthesia care, but in the surgical intensive care unit, the patients' families are felt to be an integral part of the care, and there is no restriction on visitation. We're restricting for the flu right now for health reasons, but that's it. So if someone wants to stay at the bedside for 24 hours a day, they try to figure out a way to do it. This drives me nuts, and again, because of the flu, I'm able to say we don't have to have the 6-month-old child here, but there is a substantial, Marianne and some of the other staff feel very strongly that, the child is also a part of the patient's family and the patient's family unit and who they are, and the family should decide who should come. This one drove me nuts as well. Family is welcome during procedures. Not all family wish to be there, but many are. All right, so this debrief, this I'd never seen before. This was a couple episodes where we invited the patients and the families, and this was both survivors' families and non-survivors' families to come and to essentially a conference for several hours. I was a trained facilitator, and the participants were provided with questions in advance and were asked to really just sort of tell their story and talk about critical illness and what brought them to the ICU, what they remembered, if anything, what their suggestions for improvements were, what kind of strengths and flaws that could we work on to make the performance better. And I think that this is very analogous to the initial kind of survey where you're saying, well, what are the problems? What can we find out? What can we do? And there was a lot of people there, a multidisciplinary team. People came in and out through the day and listened and had the opportunity to ask questions. And really the sense of being disenfranchised, of being afraid and confused by the illness, The fear of death, the fear of loss, really was pretty dominant in one of these conversations. And, the recognition of whether or not we addressed that at all for the patients and did that simple human kindness to address a fear that they might not express to us. I think that was something that we learned. It is very, very easy to not try. If someone is trying not to let you know that they're scared, it's really easy to ignore that. So we did try to use specific information from those processes. This woman was sick, I think it was 5 months on the ventilator. Mr. Lambert, we didn't think he was going to make it out, but he has made it out. He's off. I think he's out of the wheelchair now, and he comes back and visits too. She sent us cookies every Thursday for about a year. Every Thursday there were warm cookies. All right. These are the projects and knickknacks and keepsakes that somehow, make up a big part of what the families can take with them. Sometimes it helps to have something to hold. The diary project is a journaling project. The goal was to try to decrease the sense of PTSD by allowing the patients to journal, to have a way to look back and record the occurrences as they were feeling them, to remember and write down questions, to try to reduce stress. Anyone who's going to be there for more than just a simple post-op evaluation is provided a diary, and it's from previous family members. If they can be engaged, if they can remain a part of the team and give something back, it's often very rewarding. It's a simple journal. It has the logo on it, of course, right? But it's actually a nice piece. It's a nice hunk of paper. It's got good line spacing. It comes with a pen, and we give them suggestions that journaling may help. And a lot of the patients, you see the families writing down after rounds what it was that they remembered, or referring to it and saying, well, using it as a guide to remember what they want to ask. And this is it's soft stuff, but it is we consider it a big part of what we do, that the journal is there. This is the actual little script that's given. We encourage families to participate. Now, this is sort of a mishmash of different practices, and they're not in any particular order. The initiatives for early mobility, encouraging the family members to participate, to not just depend on the nurses and techs to do this. We try to do physiotherapy. This woman was on ECMO for quite a period of time. She was awake, alert, and could not wean off. It was very difficult. We got her up and out of bed in a chair, and it meant a lot. Another woman who was quite ill, she was in for a while. It was her anniversary. She was not going to survive, but they, God bless them, they got her dressed up. They served a formal dinner. She and her husband had on their wedding anniversary, and that was something that the staff gave to her, and it made a difference in their family's care. And a lot of people, it's a lot of people celebrate. I don't think I celebrate my anniversary, and there's a lot of people there. For critically ill patients, that they can come back. This is Rob, the gentleman who was there before. This is right before he went home, so he's looking a lot better. He's decannulated. He's looking pretty good right now. They've given him a lot of swag here. The cupcakes that he brought. But he's back to essentially a normal, productive life. And it's, at this point, we have to encourage him to let him go, right? We got to let him go back to his life, because our goal is not to make him chronically critically ill. Our goal is to get him past that and let him recover. But the fact that he came back and to share, it's part of his healing, and it's part of the sharing for us. Holiday season, they have a holiday blanket. Oh my goodness, we give all this stuff. They have Adopt a Family. They have a university blog for people who want to talk. This is someone who had a faculty member, and he's talking about his experience. They allow the pets to come in. I personally don't. I didn't like the harp when I came, because I thought it would be bad to be in the ICU and wake up and hear a harp. I thought that was not good. But she comes, right? She comes, and I lost where I was on my slides. I'm sorry. Yeah, there's a heart. Oh, I am definitely going the wrong way. Sorry. Yeah, I know. There's endless numbers of slides here. Yeah, so art therapy, massage therapy. I was like, what? We have massage therapy? We do. So these are things that at least they can try to offer to the patients to try to make the stay a little lighter. In the case where the stay is not going to get all the way lighter, I think that it's important that we address palliative care and end-of-life care. We don't do a good job of it as surgeons always, but we continually try to assess their patients for their understanding of their state of illness. There is often conflict in this area among the team as to when is it time to stop, when should we keep going, when should we not. But we have initiated at least a protocol to try to make sure that we address goals of care in a timely fashion for patients who are in the unit for more than 2 weeks, for the prolonged stay, patients who are on ECMO for a period of time, patients who we feel that or have a metastatic cancer diagnosis. There's an entire set of criteria, and that is based on this initial ICU project, and we're going to be implementing that now. Same kinds of things. These very patient-specific goals. There's a patient who was not going to get better after his retransplanted liver failed again. And really, what did he want to do? He wanted to go outside one more time. And so that's what the unit did for him, right? They said they went outside. They took him out in a wheelchair. He was there with his family and his friends, and he didn't die in the hospital, at least not in the building. Other stuff, there's again, like, guys, there's so much stuff. There's the blanket, this is Rob Kimball, the gentleman I've been showing in the pictures, who was chronically critically ill, and brought us cupcakes. His family contributed these hearts, and for bereavement, that one stays with the patient, one the family brings with them home. They send a note. The staff colors these. Originally, they were donated, I think, by a local pottery company, and then Rob's family went and bought some more so that they would have them. Blankets to go with the family, terminal handprints to take home. These sorts of things, as you know, are part of the end of life that they for the patients that you fight so hard for, and when it's time to not fight anymore and to make death dignified. Those are things that at least we try to do to focus on their care. Now I'm going to go back from all that kind of soft stuff, and I'm going to show some slides that look more like the usual medical meeting stuff. I cannot tell you that they're absolutely related, but I can tell you that these kinds of results are concurrent, and that our sense is that focusing totally on the patient improves also those hard outcomes, right? Not just the soft outcomes of satisfaction and comfort, but also the hard outcomes. So the team that works together, I'll tell you that right now what we're working on is the flu. If you guys don't have it, I think WashU has it. If you don't have it on the East Coast yet, I think my partner just told me they got 4 more evaluations for ECMO today. And, when did they start? It started right before Christmas for us. So the 22nd is when everyone got sick, December 22nd. And you think staffing a unit through the 24th to the 1st of January is an easy thing when you have a surge? It is not, and these guys pulled together to do it. All right. So this is one project that was done, so we're moving on to that simple outcomes based on, can you establish a protocol? Can you focus on what the patient outcomes should be? This is based on the SCCM blood transfusion guidelines. Within the anemia management protocol, we were able to reduce blood transfusion by 40%. There's a lot of blood transfusion slides in here, but this is definitely one of Lena's talks that I think the purple is us, the red is the cardiovascular unit, and basically showing differences in blood utilization across units. And as the years pass on, you can see that the computer people get a little bit smarter, and they start making these fancier graphs to tell us by which unit and what threshold we're using to transfuse. We can get a trend of the percent of the patients who are at a quote-unquote appropriate hematocrit. We can get a snapshot of who's getting done. And then we participate in Keystone ICU, which is the Michigan ICU initiative, where we report specific outcomes to a central entity, the Keystone entity, and they include transfusion variables and blood utilization. Now, despite all this great graphing stuff, I think, yes, we showed still a substantial increase in blood costs. And so you can imagine, I could just imagine what would happen if we did not try to control costs. For infection, this is, again, Keystone data, reducing VAP this is the surgical ICU, and this is the trauma burn ICU, reducing ventilator-associated pneumonia rates. These are different initiatives that you all know from patient care: chlorhexidine, head of bed, elevated, educational oral care. These are other improvements, other marks that they check us on, and Tim will remember the SAT, SBT, that's stuck for us. Different prophylaxis, adherence to ventilator bundle rates, and I can tell you that the surgical ICU and trauma burn ICU were also given an outstanding leadership award recipient from the U.S. Health and Human Services for reduction in infection, nosocomial infection. So performance can come out of this kind of teamwork and team building. This is the ARDS work. I'm going to skip right through this as an algorithm. We do ECMO. We go through all of these things. I can tell you this is, the team can do this practically in their sleep. They're doing it in their sleep right now because of the load, but we're very proud of the outcomes. And this is the hard data from Apache. We've reduced our low-risk monitored admissions. The patients only get sicker from 2003 to 2012. Mortality goes up and goes down a little bit, but compared to academic ICUs, it is pretty good. We're below par for this. And overall, I can tell you, SCCM, we were proud to receive the recognition with the Beacon Award from this organization for excellence in practice, patient outcomes, leadership, and that family-centered care practice. So I can tell you again, we have an exceptional team of people. Everyone's dedicated to the patient-centered concept of care. Patient is a priority. We try to include the families and patients with the patients, try to maintain an atmosphere of respect, and try to have the patients come back to continue the circle of support. Everyone does their part, focuses on the patient, evidence-based practice and safety. And I have to thank everyone who participated. And I think I made the room empty for that. So thank you.